Just like other parts of the body, there are receptors that respond to the adrenergic system. They're located throughout the body, and there are receptors for the sympathetic neurotransmitters. There's alpha adrenergic receptors and beta adrenergic receptors, and we'll be talking a lot about those. The dopaminergic receptors, they respond only to dopamine. These receptors, when they're stimulated, cause the mesenteric, cardiac, renal, and cerebral arteries to dilate. I just said there's adrenergic receptors throughout the body, and it's why it's sometimes confusing at all of the things that the adrenergic drugs can affect. Depending on the action of these sites, they're called either alpha receptors or beta receptors. These receptor sites are further divided into type 1 or type 2 sites, again based on the type of response that happens when the sites are stimulated or blocked. They're differentiated by their location on the nerves and divided into either alpha 1 or alpha 2 receptors. The alpha 1 adrenergic receptors are located on the postsynaptic effector cells. In other words, the cell, muscle, or organ that the nerve stimulates. The alpha 2 adrenergic receptors are located on the presynaptic nerve terminals, or the nerve that stimulates the effector cells, and they control the release of neurotransmitters. The alpha adrenergic agonist responses are a vasoconstriction or central nervous system stimulation. Remember that agonists mean that we are doing something that works along with what the normal reaction would be for stimulation of these substances. Beta adrenergic receptors are all located on postsynaptic effector cells. For instance, the beta 1 sites are primarily located in the heart, whereas the beta 2 sites are in the smooth muscle of the bronchioles, arterioles, and visceral organs. And when we talk about visceral organs, we're talking about the heart, the lung, liver, pancreas, the stomach, the intestines, and the kidneys. On page 297, there's a box that tells the organ and type of receptor and what happens when the receptor is stimulated. So I would study that box if I were you. We had agonists for the alpha adrenergic. We also have agonists for the beta adrenergic. And when the bronchial, gastric, and uterine smooth muscles are stimulated, they contract, where when the agonist is causing a response, there's muscle relaxation. We also have glycogenolysis when the agonist is responding, and we get cardiac stimulation. The dopaminergic receptors just a little while ago, and it's an additional adrenergic receptor. It's stimulated by dopamine, and it causes dilation of the vessels of the renal, mesenteric, coronary, and cerebral vessels. This results in increased blood flow. This is something that's especially important to remember when we're talking about patients that have low blood pressure, because when we stimulate these dopaminergic receptors, it causes increased blood flow to those areas. And in situations of sepsis, low blood pressure, things like that, we want to increase that blood flow. And as we'll talk about soon, we actually give dopamine as a drip in the ICUs when people have low blood pressure. So if we look at a few areas of the body and see the responses to the stimulation, we can see that in the blood vessels, with the alpha-1 receptors, we get vasoconstriction, but with the beta-2s, we get vasodilation. With the cardiac muscle, with the beta-1, we get increased contractility. At the AV node, the beta-1s cause an increase in heart rate. Also, they affect the SA node to cause an increase in heart rate as well. In the gastrointestinal system, with the muscle, the beta and the alpha causes decreased motility. It's usually not something that we're really wanting to have happen. At the sphincter level, though, the alpha-1 causes constriction, and we take advantage of that with the medications that are given to help people that are having diarrhea or having problems with being continent of their bowels. As we continue to look down at the genital urinary system, again, the alpha 1s cause constriction or contraction. With the bladder, it causes constriction of the sphincter, so we have better control of urination, and with the penis, it causes ejaculation. With the uterus, with the alpha-1, we have contractions, and we use those medications sometimes when we're inducing labor. With the beta-2s, we have relaxation, and so we look at those medications to stop labor in somebody who's in preterm labor. In the respiratory system, the beta-2s act on the bronchial tree to dilate the muscles. This works well for us when we're having somebody that has an asthma attack and they're having constriction. So the medications that we give would act on the beta-2 receptors to dilate those muscles. In the endocrine system, alpha-1 and beta-2 act on the liver to cause glycogenolysis. In the ocular area, especially the pupils, the alpha-1 causes dilation or mydriasis. So these are the medications that we're given when we go to have our eyes checked. So when we look specifically at the drugs, adrenergic drugs are drugs that stimulate the sympathetic nervous system, or the SNS. They're also known as adrenergic agonists or sympathomimetics. Sorry, I have to, it's one of those tongue twisters. The characteristics of these drugs is that they mimic the effects of sympathetic nervous system neurotransmitters or catecholamines. So these catecholamines are things like norepinephrine, epinephrine, and dopamine. So sometimes you'll see norepinephrine abbreviated as NE and epinephrine as epi. And it's not at all unusual to hear somebody ask for go get the epi. And we pretty much know what that is. Catecholamines are substances that can produce a sympathomimetic response. We have endogenous ones, which are things like epinephrine, norepinephrine, and dopamine. We also have synthetic catecholamines, which are things like dobutamine and phenylephrine. The mechanism of action of these medications are that they bind directly to the receptor and causes a physiologic response. Indirect acting sympathomimetics cause a release of catecholamines from storage sites or vesicles in the nerve endings. The catecholamine then binds to the receptors and causes a physiologic response. Mixed acting sympathomimetics directly stimulate the receptor by binding to it, and it indirectly stimulates the receptor by causing the release of stored neurotransmitters from the vesicles in the nerve endings. The drug effects of the adrenergic drugs are a stimulation of the alpha adrenergic receptors on the smooth muscles, and it results in vasoconstriction of the blood vessels, relaxation of the GI smooth muscles, which means there's decreased motility, constriction of the bladder sphincter, contractions of the uterus, male ejaculation, and contraction of the pupillary muscles of the eye. In other words, we get dilated pupils. So just remember on this one that when the muscles of the pupil of your eye contract, it causes dilation, which you would think that would cause constriction, but it actually causes dilation. So make sure that you get that one straight in your mind as you're thinking about this. In addition, stimulation of the beta-1 adrenergic receptors on the myocardium, atrioventricular or the AV node, and the SA node, the sinoatrial node, results in cardiac stimulation. And this results in increased force of contraction. We call this a positive inotropic effect. It also causes increased heart rate. We call that positive chronotropic effect. And finally, an increased conduction through the AV node. We call that a positive dromotropic effect. These will make a whole lot more sense when we get to the cardiac area in pathophysiology, which is only about a week away. Stimulation of the beta-2 adrenergic receptors on the airways results in bronchodilation or relaxation of the bronchi. Other effects of beta-2 adrenergic stimulation include uterine relaxation, glycogenolysis in the liver, increased renin secretion in the kidneys, and relaxation of the GI smooth muscles or decreased motility. So here's one of those NCLEX type questions. A patient has two inhalers that are due to be taken at the same time. One is a bronchodilator and the other is a corticosteroid. Which inhaler should the patient take first? The bronchodilator, the corticosteroid, or it doesn't matter which one is taken first? Well, the answer is A. And the rationale behind that is that when you take the bronchodilator first, it will result in a more open airway, and that allows for better penetration by the inhaled corticosteroid. And that puts the steroid farther into the lung to decrease inflammation that may be happening there. Another question. A 10-year-old child is brought to the emergency department while having an asthma attack. She is given a nebulizer treatment with albuterol. The nurse's immediate assessment priority would be to A. Determine the time of the child's last meal. B. Monitor their SpO2 with a pulse oximeter. C. Monitor the child's temperature. D. Provide education on asthma management. Well, it's pretty obvious on this one that her priority would be to monitor the SpO2 with a pulse oximeter, because during administration with albuterol, albuterol is a fast-acting beta-2 agonist, and the nurse should monitor the patient's respiratory status, including SpO2, with a pulse oximeter. She should also monitor the respiratory rate and breath sounds, and that's so that we can ensure that the medication is having a therapeutic effect. The other items, well, they can be handled after her respiratory status is stable. So what are the indications for these medications? Well, for one, the treatment of asthma and bronchitis. Bronchodilators are drugs that stimulate the beta-2 adrenergic receptors of the bronchial smooth muscles. That causes relaxation, resulting in bronchodilation. Remember, they have bronchoconstriction because of their asthma and the inflammatory responses in the lung. So we want these muscles to relax. Examples of these drugs include albuterol, ephedrine, epinephrine, formoterol, levobuterol, metoprolol, salmeterol, and terbutaline. Terbutaline, just as a side note, is often used to stop premature labor, and that's because it causes relaxation of the uterine smooth muscles. So when we have beta-2 actions or agonists, what we know is that we're going to have relaxation of these muscles. The nursing implications are that we need to monitor for therapeutic effects, especially in the case of asthma. You want to see a return to normal respiratory rate, improved breath sounds, fewer crackles, increased air exchange, decreased cough, less dyspnea, improved blood gases, and increased activity tolerance. So here's another question for you. A patient is experiencing bronchospasms after running half a mile. He has several inhalers with him. Not sure where he's keeping them, but he has several with him. Which one would be appropriate for treatment at this time? Albuterol, salmeterol, fluconazole, salmeterol and fluconazole combination, which is called Advair Diskus. So let's think about these drugs. The answer to this is A. Albuterol is a beta-2 agonist that is used for acute bronchospasm. Salmeterol is appropriate for prevention of bronchospasms. Fluconazole is a corticosteroid that is not effective for acute bronchospasms. Advair Diskus is used for daily maintenance and not acute exacerbations. With chronic lung disease, the nursing implications include instructing the patient to avoid factors that exacerbate their condition. Encourage fluid intake up to 3,000 milliliters per day if it's permitted. And what we mean when we say that is that sometimes when there's chronic lung disease, there's also a cardiac component. And so if their cardiac component will tolerate increased fluids, then we encourage increased fluids. You want to educate the patient about proper dosing, use of equipment. They may have a metered dose inhaler, a spacer, or a nebulizer, so you want to make sure they know how to use it and how to take care of their equipment. We've talked a little bit about how if we don't take care of the equipment correctly, we may actually encourage growth of fungus and things like that. So we want to make sure that they're cleaning their equipment properly. Okay, here we start into the words that the cat's been going across the screen, the keyboard with. The phenylephrine is also known as neosynephrine. It works almost exclusively on the alpha adrenergic receptors. It's used primarily for short-term treatment to raise blood pressure in patients in shock. It's also used to control supraventricular tachycardias, as a vasoconstrictor in regional anesthesia, as topical ophthalmic drug, and as a nasal decongestant. One thing to note about nasal decongestants is that we don't want to use these for more than just a few days. The indication for neosynephrine includes treatment of nasal congestion. It's an intranasal or topical application that causes constriction of the dilated arterioles and reduction of nasal blood flow, thus decreasing congestion. It acts on the alpha adrenergic receptors. Some examples of these medications are ephedrine, nafazoline, oxymetazoline, phenylephrine, and tetrahydrozoline. Another use that we sometimes see with this is for a treatment for when somebody has a bloody nose, because it will cause constriction of those dilated vessels, and that helps the bleeding to stop. The nursing implications around these medications include things like salmeterol is indicated for prevention of bronchospasms, not as management of acute symptoms. Overuse of nasal decongestants may cause rebound nasal congestion or ulceration when they're stopped. So usually the recommendation is that they not be continued for more than 5 days. I've had several different friends that got sort of hooked on their neosynephrine, and they just kept using it and using it and using it until finally somebody said, you really need to stop using that. And of course, when they stopped using it, they got this rebound congestion and just were miserable until that overuse syndrome was taken care of. You want to avoid over-the-counter and other medications because of possible interactions. Another indication is temporary relief of conjunctival congestion. So we get an alpha adrenergic receptor response. And some of the examples of drugs that we use for this are epinephrine, nafazoline, phenylephrine, and tetrahydrozoline. Another indication of adrenergic drugs are the reduction of intraocular pressure and dilation of the pupils. We may use this as a treatment for open-angle glaucoma. With this, we're taking advantage of the alpha adrenergic receptors, and examples of these medications include epinephrine and dipivefrin. So now let's think about these vasoactive adrenergics. We call them pressors or inotropes. They're also called cardioselective sympathomimetics. They're used to support the heart during cardiac failure or shock. They rely on various alpha and beta receptors that are affected, and at times there can be crossover as the dosage of these medications increase. Talk about dopamine. As a brand name, it's also known as inotropin. It's a naturally occurring catecholamine neurotransmitter. It's a potent dopaminergic plus beta 1 and alpha 1 adrenergic receptor activity medication. At low doses, it dilates the blood vessels in the brain, the heart, the kidneys, the mesentery, and the dopaminergic receptor activity increases blood flow to these areas. In higher infusion rates, it improves cardiac contractility and output. At that point, we've lost the alpha, and now we're going into, we're in the low doses, we're getting beta 1 action. In the higher infusion rates, we're still acting on the beta 1 receptor activities. At the highest doses, we get vasoconstriction. So if you look at it in low doses, we have dilation of the blood vessels, but when we get to those higher doses, we start seeing alpha 1 adrenergic receptor activity, and so we're getting vasoconstriction, which in many cases is not what we're looking for, and often there are better drugs to get that reaction. Dobutamine or Dobutrex is a beta 1 selective vasoactive adrenergic drug that is structurally similar to the naturally occurring catecholamine dopamine. It stimulates beta 1 receptors on the heart muscle and increases cardiac output by increasing the contractility, which again we call a positive inotropy, which increases the stroke volume, especially in patients with heart failure. It's an intravenous drug and it's given by continuous infusion. Just to back up a second, dopamine is also given by continuous infusion. And both of these drugs, they figure out the dose by milliequivalents per kilo per minute. And we may figure out how to do some of those math problems, but I'm really not going to spend a lot of time doing that with you guys because you'll catch that more when you're in Med-Surg 4. Epi, or epinephrine, also known as adrenaline, is an endogenous vasoactive catecholamine. It acts directly on both the alpha and the beta adrenergic receptors of tissues that are innervated by the sympathetic nervous system. It is the prototypical non-selective adrenergic agonist. It's administered in emergency situations only. It's one of the primary vasoactive drugs used in many advanced cardiac life support protocols. Norepinephrine stimulates the alpha adrenergic receptors. It causes vasoconstriction, and it is a direct stimulating beta adrenergic effect on the heart, primarily beta 1 adrenergic receptors. It doesn't provide any stimulation to the beta 2 adrenergic receptors of the lung. It's used primarily for the treatment of hypotension and shock, and it's also administered by continuous infusion. So let's back up again to epinephrine. Epinephrine can be given as a one-time dose during a code situation, and it's given as a fairly slow push because you don't want to hit it too fast. It can also be given as a drip, but it is primarily known for its use during code situations. But it can, like I said, it can also be given IV, and when it's given IV, it's given to support blood pressure. So here's another question. A patient on dobutamine drip starts to complain that her intravenous line hurts. The nurse checks the insertion site and sees that the area is swollen and cool. What will the nurse do first? A. Slow the intravenous infusion. B. Stop the intravenous infusion. C. Inject the area with ventolamine. Or D. Notify the physician health care provider. This one's a little more confusing because one of the side effects of dobutamine and dopamine is that they cause vasoconstriction at the site. And so often what we see is a blanching of the area right next to the blood vessel. In fact, in many cases, as it's infusing, you can see this white blanched area running all the way, like if the IV is done in the hand, you'll be able to follow that vein all the way up the arm, and you'll have this white line that follows the vein. And if you touch it, it's cold to touch because that vasoconstriction is keeping the blood, the areas around from getting any of the blood flow. But in this case, like I've said in other cases, especially with the the cancer drugs, is that if you have any question about whether the IV is in or whether the IV is out, you stop it. So in this case, we're looking at it and we see that the area is swollen. And again, because of that vasoconstriction, it's also cool to the touch. So we would definitely stop the intravenous infusion. Infiltrations of intravenous solutions containing an adrenergic drug may lead to tissue necrosis from excessive vasoconstriction around the intravenous site. Ventolamine is often used for the treatment of the infiltration, but the first thing that the nurse has to do is stop the infusion of the adrenergic drug. Slowing the medication will not stop further tissue damage. The physician should be notified, but the infusion has to be stopped first. The alpha adrenergic adverse effects by system, with the CNS system, we may see headache, restlessness, excitement, insomnia, and euphoria. With the cardiovascular system, we may see palpitations or dysrhythmias. There may be tachycardia, vasoconstriction, or hypertension. Some of the other adverse effects include loss of appetite, dry mouth, nausea, vomiting, and very rarely taste changes. Think again to what these drugs do to the GI system. They cause a decrease in peristalsis. If your food isn't moving through your gut, then you're going to have less appetite. You may have nausea because it's not moving through, so it may try to come back up, or vomiting. So you kind of get the idea of why you have the effects that you have. The beta adrenergic adverse effects, the CNS may cause mild tremors, headache, nervousness, and dizziness. So safety-wise, we want to make sure we keep this patient in bed, Cardiovascular side effects include increased heart rate and palpitations. The palpitations are usually related to dysrhythmias, and we may have fluctuations in blood pressure. Remember, we're using the adrenergics to keep the blood pressure up and increase the blood flow to those organs. So if the blood pressure is unstable, whatever it is that's causing the blood pressure to be low. For instance, some of the organisms that may be causing sepsis may put out a toxin that causes decreased blood pressure. So when there's more release of those toxins, then the blood pressure drops. And so then we have to give more support. Other side effects are sweating, nausea, vomiting, and muscle cramps. Drug interactions include anesthetic drugs. They can when given with the adrenergic agonists, they can cause cardiac dysrhythmias. Tricyclic antidepressants block adrenergic sites, which results in weight gain, dry mouth, constipation, dizziness, and drowsiness. MAIOs, which are used in psych nursing, may cause life-threatening hypertensive crises. Antihistamines and thyroid preparations can increase the effects of the adrenergic drugs. So think about the fact that the medications like Synthroid that increase your metabolic rate, when given with a drug, these adrenergic drugs which increase your heart rate, then when you take the thyroid medications, they're both acting on the heart to increase the rate. So we may have a very high heart rate with it. That doesn't mean that the person doesn't still need their thyroid preparations, but we just have to be really careful about how we give it and how we dose the adrenergic agonists. So we just talked about the thyroid preparations. Obviously, if I'm giving you an agonist and then I turn around and give you an antagonist, they will directly antagonize each other, and that will result in reduced effects of both of them. And this includes some of the antihypertensives. The nursing implications include things like administering two adrenergic drugs together. It may precipitate severe cardiovascular effects like tachycardia or hypertension. That doesn't mean that we don't do it. We just have to be aware of the fact that that may happen. Often dobutamine and dopamine are given together, and occasionally I've actually seen some patients on dopamine, dobutamine, and epinephrine drips to keep their blood pressure up. So it's just one of those things that we want to make sure that we're watching it. Usually there's guidelines for weaning when we're on these inotropic drugs. And so when we start seeing the blood pressure going up, we definitely are going to be weaning these medications. You want to assess for allergies, asthma, and a history of hypertension, cardiac dysrhythmias, and other cardiovascular disease. You also want to assess for renal, hepatic, and cardiac function before treatment. You want to perform baseline assessment of vital signs, peripheral pulses, skin color, temperature, and capillary refill. You also want to include postural blood pressure and pulse, if possible. You also want to follow the administration guidelines very carefully. So here's another question for you. A patient on a dobutamine drip starts to complain that he feels tightness in his chest that he had not felt before. What will the nurse do first? Will she check the infusion site for possible extravasation? Will she increase the infusion rate? Will she check the patient's vital signs? Or D, will she order an electrocardiogram? Well, if he's feeling tightness, we need to know what's going on. So checking the vital signs is the most appropriate intervention here. The patient's vital signs should be checked for any alterations. The dopamine rate should not be increased, dobutamine, and extravasation rarely causes chest tightness. Although an electrocardiogram would be prudent, it's not the priority until after the vital signs demonstrate that the patient is stable. Other nursing implications include intravenous IV administration. You want to check the IV sites often for infiltration because of the potential for necrosis. You want to use clear IV solutions. If there's any kind of precipitate or cloudiness to it, it definitely is not good. This is one of those drugs that has to be used with an infusion pump. You cannot just drip and use drip factors to figure out the rate of any of these adrenergic drugs, especially the inotropes. You want to infuse the drug slowly to avoid dangerous cardiovascular effects and monitor cardiac rhythm. Finally, you want to monitor for therapeutic effects, especially if we're using it for cardiovascular uses. We should see decreased edema, increased urinary output, return to normal vital signs, improved skin color and temperature, and increased level of consciousness. LOC is level of consciousness. One of the things that we really want to look at, often we'll give inotropes for their renal perfusion, which means that these low doses are causing the renal system to be perfused better. And with that improved perfusion, we should be seeing increased urine output.